The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanic, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Good morning, everyone. Good morning, TMD Warriors. We are here this morning for the next episode of TMD Demystified, and I'm Tony Urbanic. The topic of today is probably going to be creating a little controversy. That's okay. I'll say from the beginning, if you'd like to comment, if you'd like to criticize, I'm available, and my email will be listed at the end of the presentation. Today, the topic is going to be titled, Dentistry Ended Up with TMD by Default, and It Wasn't Ready. TMD did end up with TMD. Dentistry did end up with TMD by default because no one else wanted it. No one else thought it was in their area of expertise. The other areas of medicine did not feel comfortable treating this thing, which ended up being called TMD, earlier on called TMJ, earlier than that called Costin syndrome, from an ENT, Dr. James Costin. And it became obvious to the medical specialties and the medical services that they didn't want anything to do with this problem because these joints were attached to teeth. Now, that's actually what happened. And in the history of this, it was left to dentistry to treat it, and dentistry was not prepared to treat it. As I've said before in other episodes, hate to say it this way, I don't know other way to say it. You know, dentistry has been led down the road to be tooth doctors. And although it's portrayed early on in our career, I came through the system, started dental school in 1969, finished dental school in 1973 with a DDS and a master's degree in anatomy and cell biology. But I look back and I look at myself and my own career, and I was very unique in my class because I really paid attention to the basic sciences so that I could learn and understand them, not just to get through them so that I could get into the clinic. And because of that, and that interest, and it stuck with me, you know, it left me down a different career path, which led me into oral and maxillofacial surgery and maxillofacial reconstruction, and all the things I had the opportunity to do through my surgical career. But as I went through the system, starting in dental school in 1969, I was exposed very intermittently and very minimally to this thing that we called at the time TMJ. And so I was able to witness the progression. That is my point. The progression of this thing almost from the beginning, because it really began back in 1934 with Dr. James Costin, who I mentioned, was an ENT surgeon, otolaryngologist, who identified some of the symptoms of TMD, primarily earache and fullness in the ear, which he coined as Costin syndrome in his first seminal article. And then he presented it to, next thing he did is present it to the Texas Society of Otolaryngologists, and off we go. The concept of ear problems and ear ache developed then into headache and jaw pain. Began with Dr. Kosten, C-O-S-T-E-N. I've mentioned it and gave you the reference on this in a previous episode. But as the progress of this went on, it was thought by the medical establishment that they were not interested in treating this because they didn't feel qualified, because they didn't know what kind of relationship this was to the chewing mechanism and the teeth. And the chewing mechanism, the teeth themselves, were the area and expertise of the dentist 80 years ago, and still is. And so off we went. The next 35 years was pretty quiet, from Dr. Kosten to the next significant episode in the development of TMD being placed in the lap of the dentistry. And that was my last episode, which commented on Dr. Danny Laskin, from University of Illinois in Chicago, who did his seminal paper and did his seminal study on temporomandibular joint and coined the term myofascial pain dysfunction syndrome. That is where things really got off the rails. Dr. Laskin was chairman of the Department of Oral and Maxillofacial Surgery, and from his interest in the problem, it really came into the realm of treatment of oral and maxillofacial surgeons primarily. And from 1969, when he wrote his article, till the time I came into oral and maxillofacial surgery in 1973, there was quite a bit of work being done, not only by Dr. Laskin, but throughout the United States, on what can be done surgically to correct or ameliorate these symptoms, if possible. And then when I entered oral and maxillofacial surgery training at Vanderbilt in 1973, it was high on the list for my mentor, Dr. David Hall, to begin, I don't want to say experimenting, but using various surgical techniques for the treatment of temporomandibular joint symptoms. And that was more than my basic training, a significant amount of training in surgical access to the temporomandibular joint and different manipulations of the temporomandibular joint, sincerely hoping to ameliorate the symptoms. Beginning in dental school, I will call this era the night guard era, because when I began treating TMJ surgically, I was exposed to the basic concept throughout dentistry, at least in Middle Tennessee, where I ended up practicing for 46 years, that more than the majority, if there was anything to be done in a dental office about TMJ symptoms, it was the construction of a night guard and giving the patient a night guard, hard or soft, which covered the surfaces of the teeth, upper or lower, and nothing more, nothing less, and given to the patient and handed over as the solution for the symptoms. Now, the theory behind it was always very indescribable, because I remember asking many of my colleagues here at the time, well, how is the night guard going to help the problem? And if there was an answer, the answer generally was formed around the fact of bruxism, that it was generally accepted, probably way earlier, the 1969 and Dr. Laskin's work, that there was a relationship between clenching and grinding, bruxism, and the symptoms. And that's obvious today. Bruxism is not the only cause of TMD. It shares the cause list with acute trauma of various kinds and functional malocclusion. But bruxism is the most frequently seen, and I'm sure goes back well beyond. In fact, I just did a presentation. I did on my weekly blog, which focused on that issue, that it goes back thousands of years. Clenching and grinding of the teeth, mentioned in the Bible. Gnashing of the teeth. However, really things got off the rails and got into the responsibility by default back in 1969, then into the arms of oral and maxillofacial surgery quickly thereafter, because Dr. Laskin was an oral and maxillofacial surgeon, and then spread throughout the training programs in oral and maxillofacial surgery, who were equipped, not all programs were equipped, but many were, to treat surgically and begin learning about the surgery of the temporomandibular joint. So the era of the night guard actually spanned from 1969 to present time. I can assure you, the listener, and you may be one of them, that over that period of time, that if there was symptoms associated with headache, earache, jaw pain, neck pain, ringing, fullness, dizziness, that the general dentist would immediately pull out of his potential services a night guard. And it continues on. The problem was that dentistry only had certain services that they were familiar with, and they tried to apply the services that they were familiar with to the treatment of this problem, which got put in their lap. And they knew it was associated with bruxism. And the next thing that happened outside the oral and maxillofacial surgery arena was the general dentist focusing on occlusion and interferences in the occlusion, and it got extremely sophisticated and extremely complicated on how to adjust, change, reconstruct the occlusion to address these symptoms of the temporomandibular, coming from, acknowledge, the temporomandibular joint. I mean, back as soon as x-rays were available, some of these patients, certainly not all of them, but some of these patients showed severe to moderate damage within the temporomandibular joint that accompanied the symptoms themselves. And of course, we now know that a lot of these patients with symptoms do not show significant damage within the temporomandibular joint on x-ray, even when MRIs are used, but that the problem itself originates from now inflammation within the temporomandibular joint. And that is what I teach, and that is what I have found. And that information is present on many other episodes within this podcast. But I'm going over the history here of exactly how this happened. And once we understand exactly, at least my intent is, once we understand how this all occurred, then we can actually focus on addressing the problem itself heuristically and scientifically, which is inflammation within the temporomandibular joint. So tooth interferences were identified early as a potential treatment modality, and it just went wild. It's like complicated changes in the occlusion were expected, or simple changes in the occlusion were expected to treat the problem. Well, we now know that there is no treatment for bruxism, and that brings up another issue. I mean, I just saw a a Congress that has been called, and part of that Congress is bringing in psychiatrists and psychologists to teach how they can, teach people to relax so they won't brux. Well, that by anyone's standard does not work. Everyone has stress, and some people are more prone to brux under stress. Some people are not prone to brux under stress. Roughly 50% of the patient's population bruxes, 50% do not. Most of the patients who brux are not aware of it. But if you brux enough, night or day, clench or grind, sooner or later, you're going to overload the joint, just like a person who jogs for 30 years, like me, damages their knee. It is expected as we age, and the temporomandibular joint ages, and over a period of time, that chronic bruxism will cause damage, which leads to chronic inflammation. Well, again, during this period of time from 1969 to present time, which I consider the period where dentistry was left treating this problem without being prepared to address the real cause, which was inflammation. Inflammation has everything to do with cell biology. It has everything to do with what the effects of inflammation on the autonomic nervous system, on the immune system, and on the endocrine system. And now that we're in a latter stage of understanding inflammation itself, there is a lot of reasonably good science, although admittedly, I admit, and the researchers admit, and the papers that I review admit easily, readily, that there is a lot to learn about inflammation and the effects of inflammation on the different systems of the body. But the concept itself is it all originates from inflammation, and focusing on things that the dentist can do or the oral and maxillofacial surgeons can do, surgery to the temporomandibular joint, removing pieces of the joint, replacing pieces of the joint, repositioning pieces of the joint, has not been effective. That is why I actually stopped doing temporomandibular joint surgery roughly 12 years ago. The general dental component of our profession used the night guard for 50 or 60 years unsuccessfully. It's interesting how I know that my general dental colleagues here in Middle Tennessee used it, and used it profusely, certainly in the past few decades. They know the results of using a night guard are not effective, but they keep using it. So whether the damage to the meniscus or the interior part of the temporomandibular joint is present, what the common denominator is chronic inflammation. So we went through this surgical period between the 70s, when I started my surgical career, up until the latter part of the 90s, where most doctors, most oral and maxillofacial surgeons like myself, actually became disinterested in temporomandibular joint surgery because of the lack of successful patients and successful surgery. And now, within my local community here in Middle Tennessee, roughly, I would guess we probably have 100 oral and maxillofacial surgeons now. Where I started, we only had 6. Now we have roughly 100, and I only know maybe one other that will be willing to do temporomandibular joint surgery, and he primarily is only interested in doing total joint reconstruction. It starts out with lysis and lavage, and that is only temporary. We all know that. And then beyond that, you have total joint reconstruction. So you can hardly find an oral and maxillofacial surgeon who wants anything to do with TMD. And the general dental community has not completely got away from using other night guards, but they are certainly looking for a solution, because, as I've said before, generally speaking, across the profession, everybody knows nothing works, nothing is successful. And why it laid in my lap to figure this out 12 years ago, which I did. And my patients actually gave me the key. I was just looking and started by interviewing the patients. They gave me the key as to where to look. I looked there, I did that, it was successful. Then I had to figure out how it worked. And that story is in multiple places within this podcast and elsewhere. But the history then brings us to present time. And the present time, we have the availability of some help from some reasonably good science and papers that are out there that are beginning to investigate the relationship of inflammation to the autonomic nervous system, to the endocrine system, and to the immune system. Because there are comorbidities that are now being much more well accepted within the temporomandibular joint problem. And there is a lot to be learned about TMD and its comorbidities, it's a hard word, and its relationship to these other aspects of body mechanisms, autonomic nervous system, endocrine system, and immune system. I only brought this to your attention. It's not my intention to describe papers on this podcast. I mention papers once in a while, and you can look up references that I might reference. But the point being that dentistry itself was not prepared to take on the treatment of temporomandibular joint because they lacked the interest, really, starting with the dental schools, in focusing on the specific parts of basic sciences, which would lead to more and more doctors undertaking a basic science viewpoint on treating this problem, rather than treating the problem with the mechanisms that they learned in the dental clinic or the oral surgery clinic. But that is what happened. That is exactly what occurred. And that is why dentistry was not prepared to take on this problem. So my viewpoint and my purpose throughout the past few years is to educate and to make aware my colleagues of where to look, what to do. I made a significant effort to make a presentation in Washington, D.C. 3 years ago to the National Academy of Sciences that brought together a major meeting with multiple scientists who had interest in bringing forward the solution to TMD. And it was admitted there was no solution, and brought together many scientists. And I was able to give a 7-minute presentation. Didn't beg, but I sincerely asked them to look at inflammation. This is what I found. And inflammation is where the problem starts, and inflammation creates directly all the symptoms. And emphasize my experience at that time with over 3,000 patients being treated with a device that unloads the joint, decreases the inflammation, and solves the problem if the proper protocol is used with the device. And to my knowledge, at that time, it was not acknowledged other than the proverbial clapping at the end. But no further work, to my knowledge, had been generated from that presentation that I made 3 years ago. So I'm beating the drum. I am describing exactly what happened so that the listener has a full understanding of where we've been. You can't really know where to go and where the roadmap should be unless you understand where you've been. Hopefully that's meaningful to you. If you just take off from a dead start with all of the available mechanisms and papers and science and not science and clinical things available, you really can't take a good focus on where you need to go, because we can rule out, admittedly so, surgery is a successful solution. Night guards are not a solution. Certainly we know that drugs are not a solution. Unfortunately, I have to say that in my career treating this problem, I've seen not so often frequently, but many, many patients who have been addicted to narcotics because of the treatment by the medical community with just narcotics, pain medications, or Valium, which is very addictive. People get addicted to drugs. And then that brings up the thought of our medical community needs to be involved significantly in being educated and being made aware that TMD itself is a problem that is misdiagnosed in their hands constantly and confused with migraine headaches, ear infections, and Meniere's disease is the most common. There are some others that have crossed my path that I'm not going to mention at this time because I haven't seen it as frequently enough to be certain that it is an associated symptom of TMD, but there are several others that I have identified that are not commonly known. And with further work, I may bring this out. So that's the history, and that is the why dentistry was not prepared. Dentistry needs to take its place in the medical sciences as the doctor of the oral and maxillofacial mechanism, the first part of the alimentary canal, which is actually much more complicated than the other parts of the alimentary canal. And, so much can be done, needs to be done, other than fixing teeth. I cannot say that more clearly. I can't say it better. I'm sorry if it invalidates some people or disrupts parts of the profession. I truly am. I'm not out to create problems. I am out to create solutions. And this problem, this disease we now call TMD, is the perfect example that should bring dentistry and medicine together in a general concept of understanding a problem of mutual interest. Mutually interested because the physicians see the symptoms much more often than the dentists do, and the dentists are the ones who are left to treating the problem. So it's obvious that the two professions need to come together, get their heads together, get their work together, clinically, professionally, and focus intellectually and scientifically on studying the actual cause and how to decrease that cause, which is inflammation within the temporomandibular joint itself. With that being said, I'll wrap it up today. I encourage comments. I encourage criticisms if you'd like. I'm available to talk to anyone at any time. I look forward to the next time that we speak. I get to speak to you, and I definitely appreciate your attention and following me in this episode and any other episodes on this particular podcast. I am Tony Urbaniak, and this is TMD Demystified.